Okay, I'm just going to go over some of the problems that were in the Unit 1 extras. These are mostly problems about pharmacokinetic stuff, so I think that's worthwhile. The first question is a pharmacokinetic absorption question, and that's asking if you have a molecule that's a weak acid, is that good for PO administration? Yes, and the reason is, as I have the little mnemonic back in the other video, a weak acid is best absorbed through membranes. In other words, it's fat soluble in low pH. And the other way to say that is acid environment. So if you take a pill and you swallow it and it falls into your stomach, the pill was usually started out water soluble, but when it gets to the low pH, it definitely no longer has a charge. So I think the example I gave in the other video, it was aspirin, which is a weak acid. Okay, so aspirin, if it's in a high pH environment, so high pH meaning basic environment, then there's hardly any protons around to neutralize the charge on the aspirin. So the charge is therefore present, and so it's a polar or ionized molecule, which means it's water soluble. But if you take aspirin or another weak acid and you swallow it as a pill and it falls into your stomach, and the low pH, remember low pH is acid, high pH is basic because it's a negative logarithm, which can be confusing. So low pH means lots of acid, meaning lots of free protons. So when aspirin, the molecule, falls into this acid, there's these protons there which bind to it and make it nonpolar. Because the minus and the positive charge cancel out. Now, this is, and you might say, okay, yeah, aspirin, you take it early, whatever, I can't take it. The reason this is important is, say you have a patient, and this is the classic example with aspirin. Say you have a patient who's got an overdose of aspirin. That used to happen all the time when I was a kid because children's aspirin used to be a thing before Reye syndrome was discovered. So if you have a patient who's got overdose on aspirin because they took giant handfuls of aspirin, one of the things that you can do to speed up the excretion of the aspirin is to make it charged, right? So if you make the molecule charged, it's water soluble, and that means that every time the molecule goes past the kidney in the bloodstream, it'll leave with the urine. So a molecule that is water soluble will leave the body in the urine if it's got charge on it, right? So what you can do is if a patient overdoses on a weak acid, like aspirin, what you can do is actually increase the pH of the blood. You don't have to do it very much, a little teeny tiny bit, will convert most of the uncharged aspirin in the bloodstream into charged aspirin. And that way when the aspirin goes past the kidney, it'll be excreted out. So that's a sort of a theoretical thing, and actually, as far as I know, when I was in practice, that was still something that people did, which was if you had an aspirin overdose, you would make the blood a little bit more basic by giving the patient something like IV sodium bicarbonate or something like that. So if you make the blood pH a little bit higher, more of the aspirin is charged and it's more water soluble. Okay, anyway, I'm getting off track here. Okay. Then the question is, imagine you're a drug company, you want to manufacture an injectable form of this, and you want the IM form to be dissolved in water. Now, this one asks about diazepam. Diazepam is sort of famous for not being very water soluble. In fact, I think it has to be dissolved in some kind of alcohol because it's difficult to dissolve. But if you want something to be dissolved in water, oh God, why can't I? Okay, so if it's dissolved in water, it's going to be best dissolved in water if it has charge on it. right? So if you want, say, an acid to be dissolved in water, weak acid to be dissolved in water, that's going to be charged in a basic environment, right? So it's fat soluble in an acidic environment and water soluble in a basic environment. So basic environment, again, that's high pH. And high pH is all relative. It's not like you have a pH of 14 in your bloodstream. It might be the difference of your pH, the pH of your bloodstream being a little higher than water compared to the low pH in your stomach, which is like negative, which is like 2. It doesn't have to be a huge pH change because it's fine. All right, so weak acids are charged in a basic environment, like I just set up here. We can use that clinically if we have somebody with an overdose of aspirin and we're trying to get it to clear out of their system as fast as possible. People talk about flushing the system by having someone drink a lot of water. I mean, I guess, or cleanse it. It sort of doesn't work that way. I mean, yeah, I mean, if you're properly hydrated, you're going to make more urine than if you aren't. But the real trick is figuring out a way to get the molecule to stay in the urine side and not come back into the bloodstream. So if you had a weak base drug, right, that's going to be lipid soluble in a basic environment and charged or water soluble in an acid environment. Oh dear, so difficult to spell when you're on camera. So weak base is charged in an acid environment, so low pH. And so that it means it'll be charged in a low environment. So if you have a weak acid and you want to dissolve it in some water so you can put it in a syringe and put it into somebody's IV, then you're going to want the pH to be a little bit higher in order to get it to dissolve. So you can make the pH higher using something like sodium bicarbonate. A weak base, if you want that to dissolve in water, you could make it a little bit more acidic. So you could add a little some sort of acid to it. I think, is it citric acid? No, that can't be right. I can't remember what pharmacists use. I'll have to look it up and add it later. Okay. Right. So it's just a question. Oh, sorry. So this question was really just about how to dissolve things in water. Okay. All right. On C there it says diazepam is available as injection and is actually a tremendous pain to dissolve. It's also infamous for being unable to mix with other drugs because mixing it with other drugs causes it to fall out of solution. In other words, falling out of solution means it becomes solid again. It's not dissolved. And when you have two drugs that you can't have in the syringe or the IV at the same time because they'll make the other one precipitate, that situation is called incompatibility. So if you have incompatibility, then that's what that means. So if you look up a drug on the internet and it says incompatibilities, that doesn't mean necessarily drug interactions. It just means they're incompatible in terms of injecting into somebody's IV. Because if you put them in together, they turn into a precipitate and a solid, and you do not want solids going into people's blood vessels. That is not good. Okay, hold on a second here. Right. Okay. All right. All right, the next question is this question about Seizaway. Where did I put it? All right, so the next question, I'm just going to put it here. Okay, so the next question is about protein binding. So it says 24-year-old Sally R. has epilepsy, a seizure disorder, and she takes 10 milligrams of Seizaway, that's not a real drug, I made it up, every day to prevent seizures. Seizaway is usually 95% bound to blood proteins, and overdose can cause a heart arrhythmia. So I've told you what the toxicity is of a drug. So that's usually going to be the drug that you're going to be focusing on, right? So if I give you toxicity with an enzyme problem, that drug is probably the one that's the substrate. And so here also we're going to say the Seizaway. So we're going to be looking at, is the level of Seizaway in her bloodstream too high or too low? If it's too high, she gets an arrhythmia. If it's too low, she has a seizure because it's a seizure drug. All right. She calls in complaining of heartburn, and you suggest the over-the-counter drug Pukaway, also a pretend drug, which is also 95% bound to proteins. All right. 3 days after you see her, her husband calls to say Sally is in the hospital, and he was told that it had something to do with her drugs. All right. If we assume that Sally did not change her dose of Seizaway, in other words, she's been taking it the same times a day, every day for whatever amount of time, is she in the hospital for seizures or arrhythmias? Okay, so the idea, this has to do with the idea of protein binding. So drugs, a lot of drugs, when they get to the bloodstream, they're sort of carted around in the bloodstream by molecules, big proteins in the bloodstream. So that's like albumin or one of the glycoproteins. There's a big one. There's a bunch of molecules that drugs can stick to. And any molecules of drug that are stuck to a protein are not available to bind receptors and that kind of thing. So it's as if that molecule of drug is no longer available to bind. It's still in the body, but it's not doing anything because it can't have a yay effect by binding a protein. Okay. So if you imagine, I like to imagine albumin, let's say albumin, is like a little bus. Okay, so here's albumin, the albumin bus. I'm not great at drawing buses, but here we go. Here's a bus. Okay, and let's say the bus has, I don't know, five seats in it. Okay, so when this patient was taking the Seizaway, right, a certain percentage of the drug was binding the bus, right? So if you have 6 molecules of drug, here's the Seizaway. Okay. When the albumin rolls up, there's seats available for 5 of these, right? So 5 of them get on the bus, the albumin bus, and there's 1 left, right? So if this is the only thing that affects free drug levels in the bloodstream, then we would say that protein binding is having a very strong effect on free drug availability. In other words, it's having a strong effect on bioavailability. Now the idea is that if you have, a few days later, the patient starts taking the Pukaway. Now we're going to draw the same bus. Okay. All right. Still only has 5 seats. So here's the dose of the Seizaway that she's been taking. All right. And now we're going to have her take another drug. I need a different color. Wait a second. Oh, God. Oh, God. Wait a second. Okay. All right. Now she's taking another drug. She's taking the Pukaway, right? So here's the molecules of Pukaway. I mean, who knows what the dose is here? Maybe they've got, well, let's just say it's the same. It's got the same potency for some reason. That there's no reason it should, but let's just say this. So let's say it's, usually she takes 20 milligrams of Seizaway, and it just happens that the dose for Pukaway is also 20 milligrams. Whatever. All right. So hopefully I don't even have to draw anything to show the problem, because there's only 5 seats here, and there's 12 guys. So if, say, 2 of the Pukaways get on, okay, and then it only leaves 3 seats for the Seizaways. All right. So say we had these 3 guys were able to get on the bus, and these 2 guys were able to get on the bus. Okay, so The problem is now that before, when she was just taking the Seizaway, 1 out of 6 molecules was free and available. If she's taking another drug that displaces that Seizaway, now she's taking 3 times the dose, right? And really, this is always, the chances are that if any change is going to happen because of albumin displacement things, that you're probably going to have too much. There really isn't a situation where the Seizaway the level will be too low, because there's no way that the 6th guy can ever get on the bus. So you could even have a situation where maybe the Pukaway binds way stronger, right? So if the Pukaway binds way stronger, then it might take up all the seats and just push these 3 guys out. Now you've got a really toxic situation. So the answer here is that you'd have an arrhythmia from toxicity. Now, I think I asked 95%, which is a bad choice in terms of drawing a picture, because 95%, that's 1/20th. So you're welcome to figure it out again, but basically it's the same idea, but instead of 6 guys waiting, you have 20 guys waiting, right? And you have a bus with 19 seats. I guess it's a double decker. It's the same idea though, okay? So the problem is that if you have protein displacement by another drug that's binding protein, you have a problem. Now, the idea that this is the reason you get drug interactions because of drug displacement, because another drug binds the exact same spot, that seems to be going in and out of favor. When I was in med school, which would have been the early 90s, this was the way you learned it. And then I think in the late 90s and early 2000s, everyone was saying, oh, no, that's not really the cause of the drug displacements. And it looks to me like that idea of drug displacement is coming back. What the mechanism is not that important to me for this class. Okay, if you're going into pharm or something like that, then you probably want to look into that later in your career. But for this class, I think if you have this idea that the albumin only has a certain amount of spots that it can bind, then this should make total sense. And we're just going to go with that, because if there is a drug interaction, it's there. And what the molecular explanation is sort of less critical or less important, at least to me. Okay. So for the next question, you're watching TV. There's a commercial for a new pill called Hodopine. And an announcer reads a long list of complaints, or disclaimers, among which is, if you have a kidney disorder, you may need a lower dose of Hodopine. Even though you may know nothing about this drug, a person with kidney disease might need a lower dose because the kidney is important for excretion, right? So if you have lowered excretion of a drug, and the patient is just taking the doses, every 6 hours or whatever, as they're supposed to, and they continue to take the doses, the level's going to get too high, so you need a lower dose. Similarly, with a patient with liver disease, they might need a lower dose. The liver is important for drug metabolism, or drug biotransformation of some kind. All right, so if the enzyme in the liver is deactivating the drug, in this case, Hodopine. Anyway, if it's deactivating the drug, then if the liver's gone, then the drug is not getting deactivated or changed so that it'll be easily excreted, so the level will go up. Now, why might a person with liver disease need a higher dose? I mentioned this in class in passing. Not all drugs are deactivated in the liver. Some drugs are actually activated in the liver. Those drugs are called PRODRUGs, because without the liver activation, the drug just floats around in your body as a molecule that doesn't bind anything or do anything. So an example of that is something like codeine. Codeine is biotransformed in the liver to its active form, which is our buddy morphine. Right? So if a patient has liver disease and they have lower levels of the enzyme that does this, it's not really chewing stuff up, it's sort of making things better. If there's a lower level of that, then the codeine won't get transformed into morphine and it won't work. So hopefully that makes sense. Okay, the next question is, Mabel and Jack both have pain in their legs from the exact same pain from diabetic disease. I give them both the exact same dose of hodipine. Mabel's pain is relieved completely, but Jack's isn't. And so the question is, give as many pharmacokinetic or pharmacodynamic reasons why two people would have different responses to the same drug. So this is pretty much all the stuff we've talked about. So you can have different absorption, right? So maybe Mabel has been drinking alkaline water and taking antacids, and Jack hasn't. So if it's a weakly acidic drug, then the person with the antacids won't have as much drug absorbed. Additionally, maybe one of them has a stomach stapling operation, so they're not going to have as much absorption. That can happen too. In terms of distribution, if it's a fat-soluble drug, women, generally speaking, have higher percent fat content than men. So Mabel might have more of the drug going to her fat, and so she'll have lower bioavailability of the drug than Jack would. That's just an example. In terms of metabolism, right? They might have different liver function. They might have, one of them might not have the enzyme that's required to either deactivate or activate the drug. Those can be problems too. And then excretion. If it's a drug that's primarily excreted through the kidney, then one person's kidney might be in better shape than the other. Then there's things just like in terms of dosing, right? So if it turns out that Mabel weighs 80 pounds and Jack weighs 280 pounds, well, if the drug is dosed by body weight, like something like prednisone, then the dose is not, the dose that works for Mabel isn't going to work for Jack because it's too low of a dose because he's a really much bigger person. He's like some big giant, like the fridge from the Bears. Oh my God, dating myself. So that's another thing. In terms of pharmacodynamics, you can have something like they might have different forms of the receptor for that drug. They might have different sensitivity of the receptor. They might have receptor downregulation. So that's another reason why patients might have different responses. So go through the pharmacokinetic stuff in particular. And for each example I give of the pharmacokinetic changes, just think about it in terms of comparing it from one patient to the next. Because the situation will come up where you give a drug to a patient and you come back later and either the drug didn't work or it made them sick. And you have to figure out how that happened. Okay? All right. What do we have next? All right. Most drugs are category C when they are, okay. Most drugs are not tested on pregnant women for, I think, obvious reasons. You wouldn't be able to get volunteers for one thing. But when hodipine, the made-up drug, is finally FDA approved, it is listed as category C. How was the FDA able to determine the pregnancy category for hodipine without having tested it on pregnant women? Well, category C means that it caused mutations in animals. Oh my God. So difficult to write. Okay. D means causes mutations or birth defects in people. And X is like really bad, really bad for babies. Oh, this isn't going to work if I don't show you the picture. Shoot. All right, I'll start again. The next question is about pregnancy categories. So it says here, when hodipine is FDA approved, it's listed as category C. How is the FDA able to determine the pregnancy category of hodipine without having tested it on pregnant women? Now, before I say anything else, I should say that this pregnancy category business, A, B, C, D, and X, is supposed to be going out of fashion because in, I think, 2014 or 15, the FDA came out and said, okay, we don't want category A, B, C, D, and X because it's too vague. What we want instead is for people to release a drug with a really complicated explanation of exactly what mutations happened when. And the reason, I assume the reason for this is that patients, if a woman has a birth defect in her child, I mean, about 2 or 3% of the population has birth defects for no apparent reason, just from like the radiation of the sun or something. I mean, I don't know. But if you've been taking a drug while you're pregnant and then your kid has a birth defect, you're going to think, well, the drug caused the birth defect. That's going to be your immediate thought. And then you go to court and sue. And then usually people say, okay, you have a deformed baby, so we're going to give you this money, even though it's really not the drug's fault. In order to, I guess, have more, I mean, I don't know what the reason is. But anyway, however, most drug manuals and most people in terms of shorthand still use this old thing. I should have written here, category B means safe on animal testing. Right. So when they gave this drug in the preclinical trials, the animals that were tested, when they had a litter of babies, there was not a higher level of birth defects than just the baseline. So when a drug is released, there's been no testing on pregnant human women. So the best that you can say is that the drug is category C because it caused birth defects in animals. Usually what happens is people end up having to take the drug when they're pregnant for some reason. Usually it's a life-saving reason or something really important because nobody wants to prescribe drugs to pregnant women for the reason I've already said. So sometimes drugs are changed in terms of their category, in phase 4 trials or after release when, for whatever reason, women are taking this drug when they're pregnant and then there's birth defects and then the birth defects seem to be in a higher rate than what you'd expect just from the normal rate of birth defects. So when my sister was pregnant, I told her, I said, don't take any drug that's category B or C unless that drug's been out at least 10 years. Because you got to wait for people to have birth defects before you can say, yeah, that causes birth defects. Now, in some situations, you can guess that it will because, like, if the drug's a benzodiazepine and you manufacture a new type of benzodiazepine, then, you're going to probably be like, yeah, it's probably category D or X. But not always. So that's why you can have a pregnancy category on a drug that's never been tested on pregnant women. And that's always going to be a category B or C in terms of animal testing. I hope that makes sense. Okay, next question is about this idea of placebo effect. So again, this is a pretend drug I made up. And it says that there was a 3-month drug trial. This would have been a phase 3 trial because there's so many patients, right? This is a phase 3 trial done on college students aged 18 to 25. And the following adverse effects were reported. So in the patients, when a patient is in a clinical trial like that, they get a little survey, a little sheet that they fill out. Have you had any of these common symptoms? And then if they have any kind of problem while they're taking the drug for those 3 months, they report it, and the people running the study, take that into consideration. The problem is that there's a certain amount of side effects, or actually just symptoms, that people have just in terms of being alive. I mean, if the trial's long enough, almost always it ends up being 18 to 20% of the patients at some point during the trial had a headache. Also, nausea, dizziness, and rash are, people just get those. So the idea of placebo effect is not exactly what you would probably learned as a civilian. So a civilian would say, a placebo effect, that's when you give somebody a fake pill and then they think it works. Well, that can be called a placebo, effect in that term. But when you're talking about placebo effects in studies, what you mean is if I meet one of the people who had a headache who took that drug, okay, and I say, did that drug cause a headache? They'll say, yeah, I took the drug and I had a headache, so the drug must have caused it. But that's not the case because there's a certain percentage of people that have headaches anyway. So in this study, 18%, so 18 out of 100 people, every 100 people, of patients reported having a headache during the trial at some point when they had the drug. But only 4% of the patients who took the drug reported having a headache, which means that there were 14% of people, right, 18%, 14% of the patients that were going to have a headache didn't have a headache with the drug. So the drug didn't cause the headache, and if anything, the drug treated the headache. And that's how a lot of drugs are discovered to have different indications, is they're found to actually alleviate some extremely common placebo effect, and the drug manufacturer says, wow, this drug didn't work too well for what we thought it would, but it's great for headaches. So, then they put in for approval for the drug as a headache medicine. So if anything, I think you could argue that this drug actually cures headaches because 18% of people were going to have it anyway, and 14% of these people that were going to have a headache didn't have one. So that's why you can't go by testimonials. You can't have a patient who says, "Oh yeah, I took this drug and then my thumb fell off or something." Well, maybe your thumb was going to fall off anyway. So the only way to find out if that problem actually came from the drug or not is to do a controlled blind clinical study where you are giving some of the patients the real drug and some patients a drug that looks like it but isn't real. Now, by the way, you should just know that placebo is not something you should ever get or ever give to a patient. You should never get it from a doctor or a nurse. That would be illegal. You're not supposed to give anybody a pretend pill. So that's that. Anyway, so in this case, headache was a placebo effect. How about here? Muscle pain. Well, again, 5% of people were going to have muscle pain within 3 months, and only 2% had muscle pain. Now, that's not only a 3% difference, which isn't huge, but there were about 3,000 people in this study. So statistically speaking, it probably is worthwhile. So again, you could say this is a true effect of the drug. And it looks like this drug is great for pain because it was good for muscle pain and headache. In dizziness, 8% of people are going to be dizzy anyway. And the people who took the drug, 8% were dizzy. So that is a placebo effect, okay? Because the drug, the 8% that were going to have a headache were going to have it anyway. So we say it's a placebo effect as if it is an effect of taking a placebo. I know the terminology isn't great, but that's what that means, right? And here, a patient said, oh, I got nausea. So if this patient was nauseated that took the drug, 7% of them were nauseated, and here the placebo, 5% were nauseated. So you could say, well, 2% of people who weren't going to be nauseated got nauseated, and so that might have been a true effect of the drug. Now, if there were only 10 people in the study, that would be too small of a difference to be statistically significant. But when you have 3,000 people, it might be significant. Okay, and again, when you do any kind of clinical trial, it's really important that the patients who took the drug and the patients who took the placebo are very similar. Like if they're all 18 to 25-year-old female, Norwegians or something, then you need to have, the 18 to 25-year-old female Norwegians as the placebo group because you want to have the two groups as similar as possible or it won't make sense. What does N equals 1476 mean? That's the number of patients. Okay. What were the true side effects? The true side effects was nausea, nothing else. Okay. And placebo effects, I would say they were all placebo effects, right? All the other ones, let's say dizziness, pain, headache, these all were placebo effects. Oh my God, I can't write when I'm on camera. Holy moly. Okay. So again, it's a different use of the term placebo effect than you use as a civilian. But when you're talking about a true effect of the drug, the comparison has to be made on a similar group of people that took a placebo. And everything else about these two groups is exactly the same, or as close as possible. They're all the same race, they're the same gender, they're all about the same weight, they all have the same medical history. In order to get a statistically significant difference, that's how it has to be. Okay. It says here, if I were to take a group of 100 random students from Oakton between the ages of 18 to 25, how many of them would have a headache over the course of 3 months? All right, so if we assume that the American college students done in this trial were of the same sort of demographics as our students, which is a completely reasonable thing to assume, then you'd expect that over 3 months, 18% would have a headache. Okay, that's placebo effect. Very important. And again, if somebody says, I took this drug and it made me dizzy, and 8% of people who took the drug were dizzy, so the drug causes dizziness. No, the drug does not cause dizziness. Those people were going to get dizzy anyway. Okay. From this table, can you guess what an indication for pain might be? And pain, because it seems to really help pain and headache. Okay. Okay. Next question. Normal dose of hodopine is 125 milligrams a day. Your patient Steve, all patients are named Steve in my world, comes to the emergency room on noon on Friday. Bless you, my cat just sneezed. After accidentally taking 16 times his dose. Okay, so 16 times the dose. Now, again, if you have a therapeutic index of like 3, where 3 times the dose is going to make you sick, 16 times the dose is going to be a real problem. If it's a drug with a therapeutic index of 1,000, then 16 times the dose is going to be bad. All right. We aren't given the therapeutic index of this drug, but whatever. So we're going to assume it's 100% bioavailability because evidently he took his drug IV for some reason. When will the amount of drug in Steve's bloodstream come back down to 125? The half-life is 7 hours. Now, the way the half-life is measured, you can do it, you can do these things mathematically, but a lot of times numbers like this are learned empirically. It's the same thing with the protein binding. If you're a math expert and you understand chemical kinetic equations, things like that, some of this stuff seems oversimplified. The problem is that sometimes it is oversimplified because instead of calculating something, they just measured it. So when you measure, evidently, this drug, if at any point, time of day, all right, you gave it IV, at any point, you check the blood level of that drug, the free amount of drug that's available that you can test with your special lab test that checks availability. If you check any time of day, and this is 50 or something, 50% of the amount of drug. 7 hours later, the amount is half as much, so 25%. All right, any time of day. So at any point on this curve, it's just a mathematical thing that works. You pick anywhere on the curve. 7 hours later, the amount that's in the bloodstream is half as much. So if we start at Friday at noon, and the half-life is 7 hours, and we started with 2,000 milligrams. I hope I have enough room. Okay. 7 hours later, which is 7 p.m., right, we'll have half as much. So we have 1,000 milligrams. All right. 7 hours later, which would be 2 a.m., yeah? God, I hope I do this right. It'd be embarrassing otherwise. 2 a.m., 7 hours later, right? There'll be 500 left. Or that'll be the blood level when you measure it. 7 hours later from there is 9 a.m., I think, which is 250 milligrams are left. 7 hours from then is, 4 p.m.? So 125 will be left. So the amount of time it takes to go from the dose of 2,000 down to the level of 125 is 7 hours, 14 hours, 21 hours, yeah, 28 hours. So about 4 half-lives gets you down that far. It's the reason this graph works in this way is that it's exponential. No matter what dose you start with, every time the amount of hours goes by that's 1 half-life, you have half as much. So from your original amount, you have half as much there, another 7 hours, now you have 1/4 as much, then you have 1/8 as much, then you have 1/16 as much. I mean, you can memorize this. There's also little, shorthand things that if about 3.5 half-lives, usually about 90% of a drug is gone. And I'm not good at memorizing stuff like that. I like to just know how it works and then I can figure it out pretty quickly. So I hope I used the clock right. The most common mistake I see students make is either not figuring out the clock thing properly, or sometimes they start out with the original dose and they get so excited about dividing by 2 that they put in the next dose. But otherwise it's pretty straightforward. Okay? All right, and let's see. Oh, actually. Okay, the next question is sort of on 2 pages for some reason. Okay. Okay. There we go. All right. So, research determines that hodopine is metabolized in the liver by the P450 enzyme CYP2C8. Okay, and here I've given you a table of CYP2C8, substrates, inhibitors, and inducers. On a test, I'll either give you a table like this, or I'll give you one like I had on the quiz where it's different enzymes, and I have the substrate, inhibitor, inducer listed this way. It should be fairly straightforward. All right, so if hodopine is metabolized by CYP2C8, it's going to be a substrate here, right? So since it's not an actual drug, this is from a real table I got, you have to just sort of write it in. Okay, so here's hodopine. And it's trademark. All rights reserved. Okay. A new medical student writes for order for hodopine and asks you to help her figure out the dose. If you're a nurse, this will probably happen a lot. Okay, so the normal recommended daily dose is 125. Will you have to adjust the dose of hodopine you give Bob? And the reason you have to ask is that he's also taking these two drugs. So carbamazepine is a anti-seizure drug. It's used for a few things. Its trade name, I think, is Tegretol. Amiodarone, I think the trade name is Cordarone. Amiodarone has a lot of uses. It's used for arrhythmias. It's a really interesting drug, pharmacologically speaking, and we'll cover that in the third unit. But anyway, we want to know if these drugs are going to interfere with the hodopine I'm going to give this patient. So here's the substrate. Hodopine is the substrate. And now we just look. Can we find carbamazepine and amiodarone? And usually these things are listed alphabetically, if that helps. All right, so here's carbamazepine. And amiodarone isn't here. Amiodarone is over here, but that doesn't matter because if it doesn't inhibit or induce its own enzyme, it's not going to be important. Okay, so what we can say is that if we give hodopine and carbamazepine at the same time, carbamazepine will induce or increase the amount of enzyme. So instead of just having one little CYP2C8 enzyme sitting around, the longer you're taking the carbamazepine, and this guy's been taking it for a while, then the more enzyme there's going to be. So the more enzyme there is, the faster it's going to chew up its substrates. All right, so the carbamazepine and amiodarone probably interact, and probably the doses had to be adjusted for that in the past, but you're not worried about that now because they've been taking those drugs for a long time. But if you take the hodopine, you're probably going to have to adjust its dose too, because carbamazepine is going to make the enzymes eat it up faster, and therefore the blood level of the hodopine is going to go down, and if it gets too low, it won't work. Right? So you're probably going to have to increase the dose of hodopine. Okay? There's another example of this farther on in this handout with it's all written out and it has graphics and everything, so hopefully that'll help you. Okay. All right, so shortly after this next question, this is a bioavailability question. All right, so a rival Swedish company gets approval for its drug Hudvuvark. And the question is, first, what is bioavailability? The bioavailability is the percentage of the original dose that is free or available to do its thing, to act. If it's binding a receptor, it has to be free in order to bind a receptor. All right, sometimes drugs do things other than that, but let's just say it's free to do its thing. All right, so this is a PO drug, so it's going to be swallowed, yeah? So if you imagine this is your stomach, here's your esophagus, and here's your stomach. Not a very well-drawn stomach, I apologize for that. And here's your intestines, yeah? Okay, so we talked about before that all the veins from the intestines and the stomach all converge into the hepatic portal vein, which then goes to the liver, which breaks down however much it's going to break down. It may break down 1%. If it breaks down 90%, that's called high first-pass metabolism, but whatever. And then from the liver, it goes to the rest of your body via the vena cava. Okay, this is a terrible picture, sorry. All right, so I take a PO dose, here's the little pill, of 150 milligrams. In fact, I'm going to use a different color because my picture's so bad. Okay, So 150 milligrams in this little pill, all right? Okay, so I tell you 80 milligrams of that is absorbed into the bloodstream. And what we want to know is the percent of the original dose that's free in the bloodstream. Okay. I think that's probably better than to do its thing. I don't think that's really well spoken. So you might say, well, why do we care about the level in the bloodstream? If this is a drug that's supposed to work on like your pancreas or something, all we care about is the amount of drug in the pancreas. The problem is that it's very hard to get levels of drugs that are in tissues from human volunteers. They tend to be upset if you take giant biopsies of their innards. So the only thing we can really measure is bloodstream. So that's how everything is described, is by the level in the bloodstream. Everything else we know about the action of the drug, we always are going to end up correlating that to bloodstream levels. 99% of the time. That's how it's going to be. Okay, so what we want to know is how much of this original dose is going to get into the bloodstream over here, and then eventually to bind its little receptor or whatever. Okay, so 150 milligrams is the original dose. 80 milligrams are absorbed into the bloodstream. Okay, so 80 milligrams are absorbed. Now what happens to the other 60 milligrams? Well, you poop it out. Not 60, sorry, 70 milligrams. Right? Because 150 minus 80 is 70. So 70 milligrams of it turns into poop or whatever. You poop it out, it's not a thing, it doesn't matter. All right, so 80 milligrams of it goes to the liver. In the liver, you lose 10 milligrams is destroyed. All right. Yep. So that leaves 70 milligrams. Now, while it's in the bloodstream, another 40 stick to albumin. Okay, that leaves, what, 30? I think I could have thought out this diagram better, but oh well. And then you lose another 15 that distributes to fat, which means that now all you have left is 15 milligrams, right? So the numerical equation is 80 milligrams is what you absorb. That's what you start with. The most common mistake I see people make is they just remember something vaguely about subtracting, and so they just put 150 and then they subtract everything else. But of course that makes no sense, because you want to start with the amount that ever gets to the bloodstream at all, because the other 70 milligram here doesn't matter at all, right? All right, so the equation that you want is 80 minus 10 minus 40 minus 15, so that's that ends up being 15. Wow, that worked out. Okay, so bioavailability is always in percent, so it's the percent of the original dose. So 15 milligrams divided by the original dose, so the free is that, which equals 10%. So the bioavailability of this drug is 10%. Hopefully that makes sense. Okay. All right. Let's do some clinical scenarios now. And I think these are pretty straightforward. Okay, it's the zombie apocalypse. I like to have my exams in the form of the zombie apocalypse, because when I first started teaching, I had students who would write, I would say, what do you do now? And then they would write, refer to a doctor. And I'm like, no, you're not getting the point of the question. You need to pretend you're the only one. You have to make the decision. Okay, so also you don't want your patient to die in a zombie apocalypse, because if they die, they come back to life and kill you. So that's not good. All right, so first of all, we come across a woman who is a farmer who fell into a vat of organophosphate pesticide and has organophosphate poisoning. So organic phosphate poisoning is like sarin gas, or a lot of the pesticides are not a lot of them, but there are pesticides that are organophosphates, and these act like irreversible, or non-competitive is another way to say it, irreversible stigmine drugs. All right, so the stigmine drugs that you use for things like myasthenia gravis and other things that we'll talk about, those cause cholinergic, they increase, they're indirect acting, they increase the amount of acetylcholine in your bloodstream. Now the poisons, the problem there is they increase the levels of acetylcholine, and the level just keeps getting higher and higher and higher, which is bad for you, right? So the stigmine drugs and the organophosphate drugs the thing that they both do is they inhibit our buddy acetylcholinesterase. Right? Anything that ends with ACE is an enzyme. So if the stigmine drug works, it just temporarily inhibits that enzyme, and finally the drug wears off, and then the enzyme works again. If it's a poison like sarin gas or pesticides, what happens is a big chemical reaction happens that puts a big phosphate group where the substrate would normally bind acetylcholinesterase, the substrate being acetylcholine, right? So what happens is you have the normal nerves that release acetylcholine, right, that then bind their own receptors. If you destroy the enzyme, then the acetylcholine doesn't get broken down and the levels rise. And so pretty soon you have lots and lots and lots and lots of acetylcholine, and you get cholinergic poisoning. So cholinergic poisoning, the mnemonic all the students seem to like is sludge, which I can't remember exactly what it is. I think salivation, lacrimation, which means drooling, crying, urinating. D is for, I can't remember, gastroesophageal, emesis, maybe diarrhea. Right? I just think of it as a person who's exploding. Everything's coming out of them, right? They're drooling, they're crying, they're peeing, they're pooping everywhere. They're a freaking mess. They're vomiting. So the reason I don't like sludge is it doesn't mention two important things that acetylcholine overdose does, one of which is to lower heart rate. That isn't good for you. Okay, if your heart rate gets too low, your blood pressure gets too low. That's not good. It also doesn't mention lungs, right? Because acetylcholine in the lungs makes it hard to breathe. So this combination of things, everything coming out of you, which is very unpleasant but not necessarily deadly, right? Those are all bad. You can spot a person who, when they're pooping and urinating and vomiting all over you. But the thing that's going to kill the patient is the reduced heart rate and the difficulty breathing. And here the difficulty to breathe comes from two sources. It comes from the muscarinic receptors in the bronchioles, which make the bronchioles constrict, so air can't get through. And also, the overdose of acetylcholine eventually causes trouble with muscle contraction, skeletal muscle contraction, which includes the muscle around your chest, which are the muscles you need to breathe. Those are the nicotinic receptors. But these is all muscarinic receptors, and those are the things you really need to get on top of quickly when somebody's been poisoned like that. All right, so to save her life, if it's just a stigmine drug, which is, again, reversible indirect, what you do is you give atropine, which is a terrific anticholinergic drug. And what happens is the atropine, I'm just going to write at, I don't think that's the official abbreviation, but the atropine levels will get high enough and compete with the acetylcholine until the acetylcholine isn't overstimulating that receptor anymore because the atropine is sometimes sitting in the receptor. Now, if it is a poison, like nerve gas or some certain pesticides, not all, then you give atropine to counteract this horrible muscarinic cholinergic crisis problem. And you also give something called an oxime, like pralidoxime. And what pralidoxime is, I need another pen now. I'm out of pens here. This is a disaster of epic proportions. What the oxime does, it has nothing to do with the autonomic nervous system, anything like that. All it does is it's a chemical that will take this phosphate group off of the cholinesterase so that it can work again. Right? So the oxime is not necessary if it's just a stigmine overdose. And a stigmine overdose can happen because there are people that take stigmine drugs and drugs like it for things like myasthenia gravis and other problems. So that's an issue. Now, I should mention something on the side here. Hold on a second here. Which is, if you have a patient who, let's say they have myasthenia gravis, so their acetylcholine receptors in the skeletal muscle at the neuromuscular junction isn't as good as it should be, right? So here's the acetylcholine. Boo-doo-doo-doo. And it's binding its receptor. Here's a receptor for acetylcholine, a cholinergic receptor. And this is in the skeletal muscle. So these are nicotinic receptors, right? What happens with myasthenia gravis is, since there's less of the receptor, or the receptor isn't as sensitive, patients can't have strong muscle contractions because they don't have the apparatus set up to stimulate the acetylcholine receptor as much as it should be so that it can trigger a contraction in skeletal muscle. So what you can do is you can give a stigmine drug, so let's just give one of those. All right. The neostigmine inhibits the cholinesterase. This is in skeletal muscle now, right? And that causes an increase in acetylcholine. Yay! And now the patient can move the muscle that's affected. It might be just one muscle in their body. It might be all their muscles, whatever. That's great, but those patients also have acetylcholine everywhere else, right? Because every acetylcholine nerve terminal, there's going to be the cholinesterase there. And if you inhibit all of them, here, I should probably make this visible, that would be better. If you inhibit all of them through the whole body, you're going to have acetylcholine at every nerve terminal in your body. And the problem is acetylcholine not only binds nicotinic receptors in skeletal muscle, they bind nicotinic receptors in ganglia and muscarinic receptors everywhere, right? And if you have overstimulation of the muscarinic receptors, you get that cholinergic crisis, which is talked about, which is everything comes out of you, your heart rate goes down, you can't breathe. So what you might see is a patient who's taking a stigmine drug and an anticholinergic like atropine, which might not make sense because this is an agonist and this is an antagonist. So you might say, well, why bother giving an agonist and an antagonist at the same time? Well, this is an indirect agonist. It's just increasing acetylcholine everywhere. It has nothing to do with the receptor, right? Atropine only is an antagonist for muscarinic receptors, right? So the nicotinic receptors here at the neuromuscular junction can still get stimulated by that acetylcholine, but all the muscarinic receptors in all your autonomic organs won't respond to the overdose, basically, of acetylcholine because atropine will be there. Isn't that clever and awesome? And it really has something to do, what it really boils down to is receptor specificity. Indirect drugs so indirect drugs, generally speaking, increase or decrease the level of the neurotransmitter or the original ligand or whatever, something like that. Whereas direct-acting drugs bind a particular receptor. Atropine binds any old muscarinic receptor it comes across, but it does not bind nicotinic receptors. So here you have an agonist that's nonspecific and just causing acetylcholine levels to rise everywhere. But the atropine is specific only for muscarinic receptors, which means that you can still get the effect of the nicotinic receptors. It's just so cool. I just love it. Okay. I did my PhD with receptor stuff. I get very excited about receptor stuff. Okay. All right. Here is for some reason, oh, I see. She's a sniper because it's the zombie apocalypse. Okay, so here's a 46-year-old sniper who accidentally took an overdose of atropine. What are her symptoms? Well, her symptoms are going to be the opposite. They're going to be the symptoms of, they're going to be very similar to the symptoms of sympathetic drugs. So atropine in the brain, it's an anticholinergic. Oh, it's not going to fit. In the brain, it makes you sort of sluggish and sleepy. Right? But every other symptom, every other thing that it does is going to be similar to the fight or flight drugs, right? So it's going to make you sleepy. It's going to give you dry mouth. It's going to make you have dry eyes. It's going to make your pupils big. It's going to you're going to get constipated. You're going to be not vomiting. It'll be hard to urinate. Right? Your heart rate will go up, and it'll be easy to breathe. Not really a problem, but there you have it. All right. So to save her life, the thing you want to give, if there's too much atropine, right, what do we want to do? Well, if we could give an injection of acetylcholine, we'd do that, but you can't do that because acetylcholine gets broken down in the bloodstream. So what you can do is give a stigmine drug, yay! And you'll see, generally speaking, that if you have a drug that's a direct acting drug, actually it doesn't even matter. If you have a drug that's working by binding a receptor, then the agonist is going to be the antidote for the antagonist, right? So a cholinergic drug, like a stigmine drug, is the thing you give for a anticholinergic poisoning. And similarly, if you have an anticholinergic poisoning like you do here, then you give a cholinergic drug like stigmine. It's so great. So from here forward, if I say, oh, here's a patient who got overdosed with estrogen, what should we give them? Well, you give them an estrogen antagonist, right? Because you're just giving the opposite. Okay, cool. All right, here's a carpenter in a makeshift ICU. She was getting IV norepinephrine and the line infiltrated. That means that sometimes people say they blew a vein or something, where the drug that was supposed to go into their bloodstream went into the tissues. And the problem there is that the drug is very concentrated when it first goes into the bloodstream, right? Because it has to go into the bloodstream and then it gets sort of diluted within the bloodstream after it gets in and starts sort of circulating. So if you inject a alpha-1 agonist into tissues, especially tissues inside your, arm, all the blood vessels are going to constrict really strong because they're very concentrated. And if they constrict really strongly, then they will constrict so strongly that no blood gets through. And if no blood gets through to that part of your body, then it will die and you will have dead tissue. And then there will probably be a lawsuit if you did that. So what can you do? If there's too much alpha-1 agonist in the tissue of interest, the thing you give is you give an alpha-1 blocker. Yay! That's all. It's the antidote. But you got to know that it happened in order to give the alpha-1 blocker. The alpha-1 agonist thing, by the way, it's the reason why if you try to use phenylephrine spray or some kind of alpha-1 eye drop like tetrahydrazine, what's in Visine, all those drugs that are get the red out or whatever, the reason they get the red out of your eye is that they constrict all the blood vessels on your conjunctiva. And fortunately, your conjunctiva doesn't die because it's open to the air and the surface of your eye can get some oxygen from the atmosphere. The problem is that it's not getting as much as it did when there was a blood supply, and the injured or the unhappy tissue that no longer is getting a blood supply sends out factors that encourage blood vessels to grow into the space that's being affected. So people who use like get the red out drops or Visine drops more than like a week or two, what happens is new blood vessels grow until they get to the point where they can never make their eye white because their entire conjunctiva is totally covered with little blood vessels that grew because they were giving themselves these eye drops every day. So always read the package, because if you look at a package of either alpha-1 agonist given on the eye for bloodshot eyes or the nasal spray that people use to get rid of a runny nose, it'll tell you, don't use this for more than a few days. Because I've seen patients who come in with completely red eyes because they were using Visine every day for, 6 months. Okay. Johnny is a 49-year-old veteran with high blood pressure. 5 drugs that would help lower his blood pressure. Okay, so this is just a question about things that affect blood pressure. So things that affect blood pressure that we talk about in this class is vasoconstriction, right? Increased heart rate, increased blood volume. Increased blood volume is mediated through ADH and aldosterone, and we'll talk about that in the 3rd unit at more length. But really here, the biggest thing we're going to talk about is vasoconstriction and heart rate. So if we want to lower the blood pressure, then we want to drop the heart rate, and we want to cause vasodilation if possible. And we can reduce blood volume, but we'll talk about those drugs later. All right, things that drop heart rate are going to be beta-1 blockers, yeah, right, and cholinergic drugs. And that includes the direct-acting drugs that have CHOL in them and the stigmine drugs. Drugs that cause vasodilation, well, alpha-1 agonists cause constriction, so an alpha-1 blocker will cause vasodilation. And a beta-2 agonist will cause vasodilation of the essential vessels. There's not a lot of essential vessels, so the drop would be pretty tiny. But, it's a thing. And 5 drugs we've covered so far. Oh, it must be individual drugs. So the beta-1 blockers, any of the ones that end with all-lol are going to work, right? So atenolol or even propranolol will work, whatever. It'll block the beta-1 thing. The cholinergic drugs are the ones with chol in them, CHOL, especially the ones that are M2 specific. And again, there's no drug right now that's M2 specific, so you don't have to memorize those drugs because they don't exist yet. But they're in animal trials. I would say the stigmine drugs probably be all the ones. So physostigmine, neostigmine, all the rivastigmine, ends with stigmine. The vasodilation, I think I gave you prazosin and terazosin. And then the beta-2 agonist would be albuterol, even isoproterenol, something that ends with OL. Okay. And as for page 13, this is just an experiment in seeing if you know about sort of the physiology. All right, so here's a patient with a asthma attack. What are we going to use for that? Well, we want to increase the ease of breathing, so we want to dilate bronchioles. All right, so what drugs do that? All right, well, we know that beta-2 agonists do that, and anticholinergics, right? The neurotransmitter or receptor, the neurotransmitter would be norepinephrine. Actually, epinephrine is the natural ligand, not the drug. And the receptor is the beta-2 receptor. Anticholinergics, the neurotransmitter is acetylcholine, and the receptor will be the muscarinic receptor. An example drug, let's say albuterol. And commonly used drug to dilate bronchioles is ipratropium. Tends to be used more in COPD, but that'll do the same thing. All right, here's a 26-year-old hairdresser who had gallbladder surgery. She has not urinated yet. All right, so we want her to urinate. So we want to make it easier for urine to leave her body. We want to loosen up that sphincter in the bladder. So we're going to use an alpha-1 blocker, right? Or we can use a cholinergic, right? Because a cholinergic, like cholinergic crisis, everything comes out of you, including your urine. The neurotransmitter is going to be probably norepinephrine, could be epinephrine also, and the receptor is alpha-1. And cholinergic speaking would be acetylcholine and muscarinic. Luckily for all the autonomic stuff, the receptor is muscarinic, so you only have to remember one. An example drug would be one of the zosins. And a cholinergic drug, I mean, you could use a stigmine. Or I gave you, I think, bethanechol. Right. Bethanechol is a drug that's specifically used for this. All right, now, you could use bethanechol because that tends to be, I think it's M3 specific, so it doesn't have the effects on heart rate. Generally speaking, you're going to tend to use the sympathetic drugs if there's a choice, because since the sympathetic drugs are more receptor specific, you have less side effects. And here's a guy with BPH, and it's the exact same answers. All right, so if he's having difficulty urinating, you just get an alpha-1 blocker or a cholinergic. All right, so you could use zosin, or you could use bethanechol. That'll be fine, which I just gave you. And the neurotransmitter here is norepinephrine. The neurotransmitter here is acetylcholine. Okay, all right, there you go.